Hello everyone and welcome to today's live broadcast. How does the ABIM Choosing Wisely initiative affect diagnostic laboratory medicine? Presented by George Fritsma, proprietor at the Fritsma Factor, your interactive hemostasis resource. I'm Susie Valdez of LabRoots and I'll be your moderator for today's event. We're delighted to bring you this educational web seminar presented by LabRoots. LabRoots is the leading scientific social networking website and producer of educational virtual events and webinars. Before we begin, I'd like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time during the presentation. Just click on that green Q&A button located at the lower left of your presentation window. Type your questions into the box that appear on the screen and we'll answer as many questions as we have time for at the end of the presentation. Also, notice that you'll be viewing this presentation in a slide window. To enlarge that window, just click on the screen icon at the lower right. If you have any trouble seeing or hearing this presentation, click on the support button at the top right or use that Q&A button and let us know you're having a problem. Good news, this presentation is educational and thus offers continuing education credits. Click on the button in the bottom left-hand corner and follow the process to obtain those credits. Please join me now in welcoming our presenter, George Fritsma. I will now turn the presentation over to him. Welcome, George.
Hello everybody, this is George and the title of my talk is Medical Laboratory Science Educators Choose Wisely. It's a discussion of the Choosing Wisely program that is developed by the American Board of Internal Medicine Foundation and Consumer Reports. I'd like to read to you the commentary that you can find on the Choosing Wisely website, in which it gives a little history of choosing wisely. In 2010, Howard Brody, MD, published Medicine's Ethical Responsibility for Healthcare Reform, the top 5 list in New England Journal of Medicine. In this piece, Dr. Brody called on U.S. medical specialty societies to identify 5 overused tests and treatments that did not provide meaningful benefit for patients. Shortly after, the National Physicians Alliance piloted the 5 Things concept through an ABIM Foundation grant and created a set of specific steps physicians in internal medicine, family medicine, and pediatrics could take in their practices to promote the more effective use of healthcare resources. These lists were first published in Archives of Internal Medicine, and building on the work of Dr. Brody and the NPA, in April 2012, the ABIM Foundation, along with Consumer Reports, formally launched the Choosing Wisely campaign. The release of top 5 lists from 9 specialty societies. The widespread media coverage from nearly every top-tier outlet, along with positive reaction among the healthcare community, inspired 17 additional societies to join and to release lists in February 2013. More than 70 societies comprising over 1 million clinicians are now partners of the Choosing Wisely campaign. In 2013, the ABIM Foundation received a grant from the Robert Wood Johnson Foundation to advance the Choosing Wisely campaign by funding 21 state medical societies, specialty societies, and regional health collaboratives to help physicians and patients engage in conversations aimed at reducing unnecessary tests and procedures. In 2015, the Robert Wood Johnson Foundation awarded a second grant to the ABIM Foundation to continue this important work. So by way of illustration, let's talk about the Duke bleeding time. W.W. Duke was at Johns Hopkins University and just 2 years out of medical school when he established that platelets come from bone marrow megakaryocytes, that they are needed in blood clotting, and that low platelet counts were associated with bruising and with bleeding. Dr. Duke developed the bleeding time test. Actually, it was first reported in 1902 by French physicians, and it may have been around for a long time before that, but Duke actually developed the test and wrote some guidelines. He said we should puncture the earlobe with a surgical blade, start a timer, dab the wound with filter paper every 30 seconds until the bleeding stops, then stop the timer, and the normal range is between 1 and 9 minutes. Prolongation could go to as far as 30 or 40 minutes and would signal a low platelet count, a functional abnormality of platelets, von Willebrand factor deficiency called von Willebrand disease, or low or missing fibrinogen called afibrinogenemia. The earlobe wasn't such a great idea. In fact, I've done several of the Duke bleeding times myself on earlobes, and if it's cold, you can't get any blood out of an earlobe at all. And so some folks modified it and collected the sample from a fingertip instead. Well, an improvement was developed in 1935 by Dr. A.C. Ivy, who standardized the bleeding time more by suggesting that you place a blood pressure cuff on the upper portion of the arm, inflate it to 40 millimeters of mercury, and make an incision parallel to the length of the arm on the forearm inner surface. This photo that's on this slide is a little hard to decipher, but it is actually a photo taken in the 40s of one of Dr. Ivy's poor medical student assistants who had many, many bleeding times done, and they were checking to see if the cut should be parallel or perpendicular to the arm. So you're looking at an arm with dozens of parallel and perpendicular cuts, and as you can see, it left scars. By the way, I've allowed students of mine to practice on my arm, and I have so many scars on my arm now, it tends to alarm the Red Cross people when I go to donate blood. The bleeding time is used as a screen to predict surgical bleeding from the time of A.C. Ivy, and people with prolonged bleeding times were taken off the surgery schedule. I have personal experience with this. When I was 14 years old, I had a tonsillectomy. It was my first time in a hospital laboratory, and there the laboratory technician did the little cut on my arm, dabbed, and got the timing, and explained to me that it was a way to predict whether I would bleed in surgery. A tonsillectomy is actually has some risk of bleeding. There's about a 1% risk of post-operative hemorrhage in tonsillectomy, so it seemed like a really good idea to perform the test. Well, Dr. C.H. Mielke in 1969 improved further on the test by developing a little metal template that you could press onto the arm and then make the incision with the surgical blade and try to make it standardized to 1 to 2 millimeters deep by 10 millimeters long. This soon was developed as the Simplate by a company that was formed called International Technodyne, and they had a little, call it an automated device, where you could click on a little trigger, the blade would come out, it would make a precise cut, exactly like the Mielke bleeding time. The Simplate was a little bit of a risk because the blade would stay exposed, and so it would be a risk to the operator and to anybody who collected the trash. So a rival company developed the SurgiCut, which had a little blade that actually swept and made the cut and then would disappear inside, and so it was a little simpler. International Technodyne bought this device, actually bought out the company that made it, called it the continued to call it the SurgiCut, and then they got bought out by a company that in turn got bought out by the company instrumentation laboratory, and that's who owns it today. Now I'd like to explain something called the receiver operator curve, or the receiver operating characteristic curve. This is a statistical test that is done by outcomes researchers. What they do is they will compare the false positive rate, if you can see it on the screen, that's down here, and the true positive rate here at every decision point in a test that's a continuous variable. If the curve forms a nice dog leg, as you see there, that's a good test. This can be done just you can collect the data in a regular Excel file, but you need an integrator that measures the area under the curve. And if the area under the curve is around 0.9, it's a good test. If you do the test and the area under the curve is about a 0.7 and the curve is flatter, that's a mediocre test. And if you look at the outcomes of a test where the area under the curve is 50%, you're then looking at a laboratory test that is equivalent to flipping a coin. Not very useful. And so this was applied to the bleeding time test. And it turns out that the bleeding time test is completely ineffective when applying outcomes data of this sort. The publication that is on this slide, Channing-Rogers, reviewed over 200 primary publications that looked at the efficacy of the bleeding time test in terms of its ability to predict bleeding, particularly in surgery or in other circumstances as well. And they showed, first of all, the standardization by Ivy and Mielke and so on did not enhance the bleeding time whatsoever, didn't help with its ROC analysis. The bleeding time is not a specific indicator of platelet function at all. It's affected by hematocrit, by platelet count. It's affected by the thickness of the skin, by how intact the blood vessels are, and so on. It does not predict the risk of hemorrhage in surgery or in any other condition. Prolongation doesn't occur ahead of actual bleeding symptoms. If the bleeding time is prolonged, chances are you've already noticed bruises on your arms and legs. And it's not useful in testing the efficacy of therapy. Now, we did use the bleeding time back in the 90s to see if aspirin was effective. Aspirin will prolong the bleeding time because it disables platelets. However, that testing got dropped in favor of tests that are much more specific and reproducible. So just in summary, the bleeding time, even though intuitively seems like a great idea, it is useless and it leaves scars. Now, despite these findings, it still is available. It's being sold still by instrumentation laboratory, and it is being used around the world. However, it is best to discourage the use of the bleeding time as it really has no predictive value. The information that's been collected on the bleeding time was summarized in this Choosing Wisely recommendation developed by the American Society for Clinical Pathology, and it simply says don't use the bleeding time test to guide patient care. The bleeding time test is an old assay that has been replaced by alternative coagulation tests. The relationship between the bleeding time test and the risk of a patient's actually bleeding has not been established. Further, the test leaves a scar on the forearm. There are other reliable tests of coagulation available to evaluate the risks of bleeding in appropriate patient populations. Most laboratory directors, I will say, have tried to ensure that none of these surgicuts are around and that people aren't doing the bleeding time test anymore. A more sophisticated test is the prothrombin time, or the PT, or the pro time, that was developed by Dr. Armand Quick in 1935. And the pro time is prolonged by deficiencies of many coagulation factors, plasma coagulation factors, of the extrinsic and the common pathways. I'll have a diagram in a moment to explain that. And so factors 10, 7, 5, and 2 cause prolongation of the prothrombin time, and so does liver disease, disseminated intravascular coagulation, and vitamin K deficiency. Dr. Quick used it as an early test for liver disease because the liver makes all of these factors. And then in 1953, when we started using the oral anticoagulant Coumadin, which had been developed in the 1940s as rat poison, it turned out to be effective in preventing ongoing thrombosis. And we then began testing for Coumadin therapy using the ProTime, which was further refined to the international normalized ratio in 1980. And furthermore, we now have the prothrombin time as a standard admission screening protocol at all medical centers. Likewise, we have the activated partial thromboplastin time. It was started in 1968, and it's gone through several iterations, like the recal time, the Macallan clotting time, the partial thromboplastin time, and then the activated partial thromboplastin time, depending upon how the reagent was formulated. The activated partial thromboplastin time had in it phospholipid, calcium, and a negatively charged activator. Now, that's the only kind of partial thromboplastin time test we use nowadays, so most of us have gone back to just calling it the PTT. We've dropped the A from the name. And it's prolonged by deficiencies of the coagulation factors 12, 11, 9, 8, 10, 5, and 2, and has also been applied to monitoring unfractionated heparin in inpatients since 1970. But in addition to that, the PTT is now part of a standard admission screening protocol for all hospitals. This slide diagrams the coagulation mechanism, and if you start over at this point, the extrinsic mechanism starts with activation of factor 7 by tissue factor, and it goes down this pathway activating 10 and 5, there's 10, there's 5, and activating thrombin, and eventually converting fibrinogen to fibrin, which forms the clot. The prothrombin time reagent includes tissue factor that emulates this material, calcium, and phosphatidylserine, which is a phospholipid, and it starts coagulation at this point. It triggers factor 7 activation and on down through 10 and 5 and thrombin and fibrinogen. On the other hand, the PTT reagent that consists of calcium, a particulate activator that's negatively charged, and phosphatidylserine triggers coagulation at the level of factor 12. Factor 12 then activates 11, 11 activates 9, 8 is part of that complex, and then that goes on to activate 10 and 5, which are part of the common pathway. And so the PTT and the PT together measure coagulation deficiencies in every part of the coagulation mechanism. What's happened since then is that the PT and the PTT are used as a screening combination. They're ordered on every surgical admission, nearly every medical admission, and are repeated periodically in people as they are in the hospital. They're ordered also in cases of outpatient activity, in anything that is potentially bloody, including the tonsillectomy, a bronchoscopy, cardiac catheterization. We do so many of these that, in fact, an 800-bed hospital, such as the one that I'm affiliated with at the University of Alabama at Birmingham, will do somewhere between 300 and 500 PT and PTT combinations a day, and their purpose is to screen for bleeding risk. Now, I had a personal incident in 2012. I had a bronchoscopy. The head of the Department of Pulmonology at UAB ordered a ProTime and PTT on me. I knew that they weren't really predictive, I'll show you in a moment, but I let her do it anyway. They were normal, and I asked her why she did the ProTime and PTT. And she said, only to avoid lawsuits. And I asked, did the ProTime and PTT, I asked her, does the ProTime and PTT ever turn up a positive and cause you to change your mind on surgery? And she said, no, never once. That's never happened. Now, just to explain for a moment the concept of a false positive and a false negative. A true positive is an assay result that correctly identifies those with a disease or condition. A false positive, that's an assay result that incorrectly identifies a disease where none is present, a false alarm. The true negative and false negative have similar meanings. Now you might ask, well, aren't laboratory tests absolute? Either they're positive or negative? Only in your dreams. All laboratory tests have a percentage of true positives and false positives. Now, to explain a screening test, we use the term screen rather indiscriminately, but a screen actually has a specific meaning, and that is a test on an unselected or random population. That's like if you were in the mall doing cholesterol screening on anybody who comes by. If you devise a screening test, you want it to be as sensitive as possible so it doesn't miss anybody, but it will then have a high false positive rate and a low false negative rate. If you use a screen and it comes out positive, you then need a confirmatory test that's designed the opposite way to have a high false negative rate and a low false positive rate, and that can confirm the initial screen. You wouldn't want to use the confirmatory test first, because then your false negative rate would go up. A false positive rate is, it creates a lot of extra work because you have to do follow-up testing. If you have a high false positive rate, you tend to alarm a lot of patients with these positive results, and you often have to delay a procedure or a surgical event for a patient who has a positive laboratory test, although it turns out to be false. Now, a high false negative rate is more dangerous because you might miss an existing disorder, but it's okay to use a more specific test as a confirmatory test if you've already done the screen. This slide will be a little confusing, but it illustrates what happens if you're using a screening test on various populations. So we're looking at a population of 10,000 people, and we know from public health studies that 10% of these people in a selected sample will be positive and therefore will have the disease. 10% of 10,000 means 1,000 people will have the disease, 9,000 without. If you are using a test that has a 2% false positive rate, then about 980 of the tests will be true positives out of that 1,000, but you will have 180 false positives. Now, let's say you have an unselected or random population, but the disorder is fairly common at 1%. Now you're going to pick up 98 true positives, but twice as many false positives. Let's say you have an uncommon disorder at 0.1%, then out of 10,000 people, you would have 10 people with the disease, 9990 without. You will have 9.8 or roughly 10 true positives, but 200 false positives. And you can see how the numbers come out for a rare condition. Here you would have 200 false positives for every one true positive. So at that rate, your laboratory is just chasing its tail, following up all of these false positives. So the PT and the PTT, their efficacy as screens has been reviewed by this group in 2017. And they've looked at, for medical or surgical patients without liver dysfunction or history of bleeding or oral anticoagulant use, the routine testing of the ProTime and PTT has no benefit in the assessment of bleeding risk. And they asked, what does predict surgical bleeding risk? They looked at something called the Bleeding Assessment Tool, or the BAT. And the Bleeding Assessment Tool, developed by the International Society for Thrombosis and Hemostasis, is a carefully devised questionnaire that physicians may use to ask a patient if they've had any bleeding episodes, how serious they were, bleeding episodes among their kindred, and so on. Well, it turns out that the group that reviewed this, the BAT by ISTH, it turns out that the BAT wasn't really much better at predicting bleeding than was the ProTime, the PTT, or the bleeding time. The only thing that really predicts bleeding in surgery is the surgeon's own track record in previous bleeds. This information has led to another Choosing Wisely recommendation, again by ASCP. And they say, avoid routine preoperative testing for low-risk surgeries without a clinical indication. It goes on to say most preoperative tests, typically a complete blood count, prothrombin time, partial thromboplastin time, the basic metabolic panel, and urinalysis performed on elective surgical patients are normal. Findings influence management in under 3% of patients tested, and in almost all cases, no adverse outcomes are observed when clinically stable patients undergo elective surgery, irrespective of whether an abnormal test is identified. Preoperative testing is appropriate in symptomatic patients and those with risk factors for which diagnostic testing can provide clarification of patient surgical risk. So the question is, are the ProTime and PTT useless? No, they're not. If there is an indication, if the patient has a bleeding disorder, then those tests are useful. As a screen, however, almost all they do is produce false positives and create a lot of work and expense for the laboratory. And using the Choosing Wisely recommendation can cut back on laboratory expense, patient anxiety, changes in the surgery schedule, and all for no particular reason. One more example I want to bring up is the inherited thrombosis risk factors, or thrombophilia testing. So in 1965, Egberg demonstrated that antithrombin, which is a control protein in coagulation, when it is deficient, is associated with thrombosis. And so laboratory medicine specialists at that time thought, aha, we have the answer. We can test for antithrombin, and we can predict if you're going to have a thrombotic event. Well, it turns out that its association was relatively rare, but then in 1984 and 1986, Comp and Esmond described protein C and protein S. Those were just named for their location on polyacrylamide gel electrophoresis. So we started testing those in 1986. It really didn't catch on again because the prevalence was low. But in 1993, Bjorn Dahlbach in Sweden described activated protein C resistance, and in 1994, Rogier Bertina in the Netherlands described the actual mutation associated with activated protein C resistance and showed that it was quite prevalent in Caucasian populations. Followed up in 1996, Dr. Port in the U.S. described the prothrombin G2210 mutation, and then others looked at mutations in factor VIII, in homocystinemia, and in polymorphisms of the methylene tetrahydrofolate reductase enzyme. Well, so most laboratories developed a screening profile that included activated protein C resistance, prothrombin, antithrombin deficiency, homocysteine, and so on. I was associated with a clinical reference laboratory in Denver. That laboratory had 4 employees in 1994. It was a fairly specialized laboratory and was a fairly small business. As soon as Dahlbach described the APCR and Bertina, the factor V Leiden, the prevalence of these, which you see is 3.8%, was such that it drove a huge amount of business to reference laboratories around the world. And the laboratory I'm referring to in Denver that had 4 employees in 1994 had 40 employees by 1997 and had to move to a larger facility to accommodate the volume of work. However, it turns out that thrombophilia testing is limited. Antithrombin is an acute phase reactant, so its level rises in any case of acute inflammation. Protein C and S, their activity actually drops in acute inflammation, and furthermore, they are vitamin K dependent, and so if someone is on Coumadin therapy, then they will, their results will go down. And all 3 have a high false positive rate. So in 2004, Dr. Musa Marcus, who I worked with at University of Alabama at Birmingham, and I examined 3 years' worth of thrombophilia test profiles. That's our profile. And we found that over the 3-year period, there were 20% of the protein C and protein S's were deficient, making you think that these were all people who had a combined protein C and protein S deficiency. Now, the prevalence or the possibility of both being deficient is 1 in 30,000, so it's quite unlikely. We heard a talk by Dr. Craig Kitchens from Jacksonville, who said that he knew of a lady who was pregnant who was told she had protein C and protein S deficiency, the risk of thrombosis was so high that her physician told her to abort the pregnancy, and she did. Well, the reality is that the protein C and S levels are low because they were ordered at the wrong time while the patient was on Coumadin therapy. And the Coumadin therapy causes both C and S levels to become diminished. And so with problems like these, a lot of work has gone into looking at thrombophilia testing indications. And the most important piece of work that has been done was developed by Dr. Ravi Sarodi at the Department of Pathology in the University of Texas Southwestern Medical Center in Dallas. And so what he did is looked at 2 months of thrombophilia testing people in 2009. And it was just a retrospective study. They just looked through all of the electronic health records, and they looked at the indications that should accompany thrombophilia testing, including recurrent pregnancy loss of 3 or more instances, an unprovoked arterial thrombosis or venous thrombosis, or pregnancy morbidity, preeclampsia, intrauterine growth retardation. And they examined a total of 173 thrombophilia test panels. They also listed those test panels that were done on people who had non-indications, and this included provoked venous thrombosis, meaning having a clot form in your leg because of immobilization or surgery or trauma, malignancy. A lot of people get clots in their legs if they spend 8 to 12 hours in the economy class part of an airplane. Also provoked arterial thrombosis associated with hypertension, dyslipidemia, and so on. Women with 1 to 2 pregnancy losses, or testing with no prior thrombotic event. So they listed both indications and non-indications, and they found of their 173 patients that 29% of the patients had testing performed without any documented thrombotic event or pregnancy morbidity. 80% who had a connective tissue or autoimmune disorder. Another 69% had a known thrombotic event or pregnancy loss, but 34% of those didn't have the appropriate indication. They also noted that 59 of their patients were on anticoagulant, 146 patients had incomplete workups, and 136 of the patients had no follow-up tests. And altogether, 85% of their thrombosis risk orders were inappropriate. And so they developed an intervention. First of all, they developed a laboratory advisory committee, and the group wrote, "Do not perform thrombophilia testing of patients admitted with an acute venous thromboembolic disorder, arterial thrombosis, or patients diagnosed with a thrombotic event during their hospital stay." Essentially what they're saying is, don't do these thrombophilia panels on anybody who's an inpatient. They went on to say investigate as outpatients if they met the criteria, young age, unprovoked event. They had to do the testing greater than 2 weeks following discontinuation of anticoagulation. And they shouldn't be done if the patient is newly admitted with a thrombotic event, a venous thromboembolic disorder, pulmonary embolus, or heart attack, because during acute inflammation periods, the tests are not at all reliable. They actually put hard stops into their laboratory electronic ordering system, which of course made a lot of physicians angry, but the hemostasis service would communicate with those clinicians to either cancel the testing that was deemed inappropriate or to go ahead and give permission for testing if it seemed appropriate. So it was necessary for the physicians to communicate with the hemostasis service. And it turned out that instead of doing 87 tests per month, it was reduced to 18 tests per month, and reduced even further to 5 per month by intervention by the hemostasis service. So they reduced their orders on inpatients by 79%. 79% sounds pretty good, but in fact, Dr. Ceroti was dissatisfied with that number because still 21% of inpatients were being tested for thrombophilia inappropriately, and so they continue to attempt to educate. Because of his work and the work of his group, Dr. Ceroti was awarded the Choosing Wisely champion status because he discovered approximately 85% of thrombophilia tests at UT Southwestern's 2 teaching hospitals were ordered incorrectly or incompletely. Thrombophilia tests are frequently ordered for patients with acute thrombotic events, often while on anticoagulation therapy. However, these additional variables cause these standard tests to return false positive results. These abnormal results, by false positive they mean low or deficient results, by the way, these abnormal results are not always checked for reproducibility or accuracy, causing some patients to be inappropriately placed on long-term anticoagulation therapy. To promote appropriate use of testing, Dr. Ceroti's team developed local guidelines and implemented them in the electronic health record via a series of cascading questions that providers must answer before ordering. After implementation of the intervention and associated education campaign, UT Southwestern has now reduced testing for inpatients by more than 90%. And this has also resulted in 2 Choosing Wisely recommendations that are roughly parallel. One by the American Society for Hematology, their logo right here, in which they say, don't test for thrombophilia in adult patients with venous thromboembolism occurring in the setting of major transient risk factors such as surgery, trauma, or prolonged immobility. And you can read the rest of that recommendation yourself because another even more specific recommendation came from ASCP, in which they say, do not test for protein S, protein C, or antithrombin during an active clotting event to diagnose a hereditary deficiency. These tests are not analytically accurate during an active clotting event. I'm currently dealing with a question on Fritsma factor about exactly how long you should wait after an active clotting event. And the answer is you can't test during the active clotting event or immediately after. And of course, the patient's going to be placed on anticoagulant therapy, probably Coumadin, or nowadays it could be one of the oral direct anticoagulants like dabigatran or rivaroxaban. And generally speaking, it's a good idea to wait 2 weeks after the treatment is discontinued to then test for protein C, protein S, or antithrombin, or any of the other thrombophilia factors, with the idea that by that time the anticoagulant is cleared and you can get an accurate result on an outpatient. Choosing Wisely has a Champions program which the participating associations recognize clinicians who are leading efforts to reduce the overuse and waste in medicine. The program was created to acknowledge the work of those dedicated to providing appropriate care and encourage others to follow their lead. Champions are selected by participating societies and include clinicians or teams of clinicians whose work in their respective specialties represents significant contributions to advancing the goals of the campaign. These can include creation of an intervention to implement choosing wisely in their clinical practice, designing local initiatives to educate colleagues, or playing a leadership role in developing society recommendations. And here are just a few examples, 3 of several champions from 2017. Mr. Jack Jordan at Henry Ford Hospital worked to make utilization of laboratory services more evidence-based. Dr. Megan Kapp, who was at Vanderbilt, worked with steering committees. These were called diagnostic management teams, educating the house staff and faculty about the harm of daily labs. And in fact, people in ICU have an average of 60 to 70 milliliters of blood drawn every day, often rendering them anemic. Dr. Pelage published research that contributed to the Infectious Disease Society of America, saying that there was overuse of tests for Clostridium difficile in certain situations, or C. diff. Here's 4 of the 2016 champions. The Cedars-Sinai Health System actually cut $6 million in laboratory testing. Dr. Altenberger decreased blood product usage by 46% over 3 years. I'll have an additional comment on that in a moment. Dr. Juarez addressed variability in blood utilization at Baylor, and she and her colleagues developed an institutional clinical practice recommendation modifying transfusion workflow in the EHR and launching an educational campaign. And also Dr. Munoz and his colleagues at Banner Anderson Cancer Center implemented an intervention design to test whether an automatic alert in an EHR could remind clinicians to carefully weigh the anticipated benefits against the risks of post-treatment imaging scans for patients with lymphoma. There's also the Choosing Wisely grant program that I mentioned at the very beginning. These are grants from the Robert Wood Johnson Foundation. These grants have supported 21 projects led by state medical societies, and in 2015, an additional 7 grants to organizations that promote the goals of the Choosing Wisely program. And those grants are ongoing, and Choosing Wisely regularly announce new grants as well. Well, there's more than 100 recommendations, and so I just threw in a couple of additional examples. One, everybody probably knows about the old erythrocyte sedimentation rate, and this came from the ASCP. They say don't order an ESR to look for inflammation in patients with undiagnosed conditions. Order a C-reactive protein to detect acute phase inflammation. That's a much better assay. The ESR should be eliminated altogether. In addition to laboratory testing, I didn't talk much about therapy, but there's many recommendations associated with the overuse of therapy. The one that turns up over and over and is best expressed by the American Association of Blood Banks is blood usage recommendation. And they say don't transfuse more units of blood than absolutely necessary. Back in the 80s and 90s, the rule was if you're going to transfuse, you better give them 2, not just 1, because 1 isn't likely enough. That has been completely reversed, and now the recommendation is to restrict blood to when the hemoglobin level is low. My slide shows the recommendation from Choosing Wisely at 7 to 8 grams of hemoglobin, but many physicians even use 6 grams of hemoglobin, and to use only a single unit of red blood cells for that treatment. So that's a typical recommendation. Now, I won't read the next 3 slides to you. I'll give you the opportunity to look at these themselves. But this represents a recommendation by ASCP that was sent to Consumer Reports and is made available to the lay public. And it's a recommendation about vitamin D testing, and it illustrates that we do way too much vitamin D testing, wasting a lot of money, and it is pitched not to the physician but to the lay individual. It's in intelligent terms, but in lay terms that most people can read. And they say, I'll just read the bottom of this slide. It says, many people have low levels of vitamin D, but few have seriously low levels. Most of us don't need a vitamin D test. We just need to make simple changes so we get enough vitamin D. We need to get a little more sun, eat foods rich in vitamin D, or take a supplement. And the recommendation goes on. It says extra tests lead to extra treatment and costs. Getting tests that you don't need often leads to treatments you don't need, or treatments that can even be harmful. For example, if you take too much vitamin D, it can damage your kidneys and other organs. This is continued on this 3rd slide, and I won't really read that. That's available for you to take a look at. What I want to get to is this. The choosing wisely people are always looking for more societies to participate. If your society would like to participate, they need to submit 5 recommendations for consideration. They must begin with the terms don't or avoid. They have to be evidence-based with current references. They must address frequent diagnostic or therapeutic choices. They're developed within the contributing society using their own processes, and they may send recommendations that overlap with other existing recommendations, or conversely, they should try to avoid complete redundancy. Choosing wisely recommendations are developed with transparency. The method is summarized with the recommendation. They're accompanied by a description of the contributing society, and the foundation sends each recommendation to 2 independent reviewers for comment and approval. The foundation then sends recommendations to all the partners to ensure that there's no conflict with existing recommendations, and when the recommendations are finally published, the copyright actually belongs to the contributing society. So our last question is choosing wisely working? And just in October, on October 25, 2017, just a week ago, there was a working study that looked at the outcomes of the Choosing Wisely activity. Only 1 in 4 U.S. doctors knows about choosing wisely. It was 21% in 2014. Now it's 25%. There was a slight non-significant increase since 2014 in the percentage who reported difficulty having conversations about avoiding low-value services, from 42% to 46% in 2017. And I'd like to read to you the statement that was issued by the meeting on the 25th. They said, "The Choosing Wisely campaign represents a practical expression of the core mission of the ABIM Foundation to improve healthcare by strengthening medical professionalism," according to Dr. Richard Barron, President and Chief Executive Officer of the ABIM and the Foundation. He said this in his introductory remarks. He continued, "How do you get from the aspiration to do the right thing to actually changing behavior to frontline conversations and frontline actions? That's what Choosing Wisely is all about." When the researchers asked physicians why they continued to practice services deemed to be low value, they listed malpractice concerns most often, followed by dealing with uncertainty and patient demand, implying that they're actually answering patient demand to have these unnecessary procedures and treatments done. However, one of the researchers pointed out that such concerns don't align with the literature on what is actually driving the practices and their impact. For example, the lead author of this effort, Carrie Cola, PhD, noted in their paper that there is little evidence that patients are demanding these low-value services or that not offering them increases the risk for malpractice suits. So the question is what to do next. And the answer to me is education, 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 and in addition to that, the use of hard stops in your electronic health record that brings the physicians to the experts for advice and help. That concludes my talk. I want to thank you for listening today, and I'll be happy to entertain questions. Thank you very much.
And thank you so much, George, for that informative presentation. We will now start the live Q&A portion of the webinar. If you have any questions you'd like to ask, please do so now. Just click on that green Q&A button at the lower left of your presentation window. Type the questions into the box that appear on the screen and click the send button. We'll answer as many questions as we have time for. So let's take a look at our audience questions that are already coming in. George, our first question from our audience is, what can MLS educators do to promote the Choosing Wisely program?
I'll tell you a project that I'm involved in right now, and that is I'm involved with the American Society for Clinical Laboratory Sciences. And the ASCLS, most of our members, over half of our members, are medical laboratory science educators in many universities and even hospitals around the country. And we've organized a task force within ASCLS of 8 members who are looking at involvement with Choosing Wisely and with developing recommendations. And the key effort that we're involved in is developing educational modules that can be fit into entry-level education for medical laboratory scientists, advanced education for medical laboratory scientists, and also for residents, hematology fellows, medical students, nurse practitioners, nurses, and physician assistants. And I think educating at the level of entry into the profession will have a profound difference.
Thank you so much, George. And thank you, audience members. We do have one more question from our audience. What about instructing patients? Can you give us a little information about that, George?
As far as instructing patients go, I personally, number one, I think Consumer Reports is a great way to access the public, the lay public. I think also those of us who are involved in Choosing Wisely have an obligation to make presentations to people at, let's say, civic organizations, churches, or other associations within our own communities. Important that we use lay terminology, but intelligent lay terminology that people can understand. We don't want to insult people with simplistic terms, but we want to make sure that people understand how so many of these activities that we do in medicine are unnecessary and potentially harmful. So that's, to me, the key is finding ways to get to the lay public with this kind of information.
Thank you so much, George. And would you like to offer any closing remarks before we end our presentation today?
Okay. I just have a couple of quick things to say, Susie. It is difficult. There have been many studies that show that educational efforts designed to change practices in medicine might be heated for a while. Let's say you have a grand rounds, you have discussion of some of the choosing wisely issues, everyone agrees, they go back to their practice, and there's no change in their performance. I know of one researcher who has developed a little 30-minute case-based vignettes that physicians can get CME, or others can get accreditation from nursing societies or medical lab science societies, and they can participate in these brief little vignettes and get credit. And this researcher has designed the back end of that program such that it measures behaviors before participation and after. That seems to be one of the more effective ways to change behavior. The other one, as I've already mentioned, I think is at entry-level education, where you can help show people what testing is important, what therapy is important, and what is overused and can be possibly harmful.
Thank you, George Fritsma, and thank you, audience members, for this wonderful presentation. I'd also like to thank LabRoots for making today's educational webcast possible. Before we go, I want to let everyone know that today's webcast will be available for on-demand viewing through February 2018. You'll receive an email from LabRoots letting you know when the webcast will be available for replay. Please share that announcement with your colleagues who may have missed today's live event. That's all for now. Thanks for joining us. We hope to see you again soon. Bye-bye.